Alrighty, welcome everyone to the ALS Hope Foundation's educational webinar. Today we have Dr. Terry Heiman-Patterson and Mary Holt-Paolone that will be presenting on ALS 101.
Great. Thanks so much, Sarah. I'm just going to share my screen here. Wonderful. All right, welcome everyone that if anybody's with us. My name is Mary Holt-Paolone. I'm the nurse coordinator and the mental health specialist at the MDA ALS Center of Hope at Temple University in Philadelphia. I'm here with Dr. Terry Heiman-Patterson, our fearless leader and wonderful educator, internationally known doc for ALS and neuromuscular care. And she is the president of the ALS and founder of the ALS Hope Foundation. So it's a privilege and honor to be with her. And we will be talking to you today about ALS 101, the basics. So Dr. Patterson will start for us, and then I'll jump in for a bit, and then Dr. Patterson will come back into the discussion. All right, so welcome, welcome, welcome.
So thank you, Mary. And Mary and I have been tag teaming for quite a while. Mary is superb, as anyone who has come to the clinic knows, and she's my right hand, and I'm right-handed. So without Mary, we wouldn't be doing anything. But today we're going to talk about what is ALS, who gets it, something about the genetics, what the cause is. Mary's going to go into what can be done, because that's really important. And then we'll end with what's on the horizon, because there's so much hope now in the disease and what's going on. Next slide. So for those of you who aren't familiar with ALS, it's a motor neuron disease, and there's damage to the upper motor neuron in blue and the lower motor neuron. The upper motor neurons, they carry the message to move from your motor area of your brain down into the brain stem, the lower part of the brain, and then into the spinal cord. And it's almost like a relay team. They pass that message off to the lower motor neuron, which is depicted as the orange arrows. And that lower motor neuron brings the message out to the muscles to move. So in the case of the lower part of the brain, that bulbar region as it's labeled, it goes to the muscles of speech and swallowing. Whereas in the cervical region, it goes to the muscles of the arm, the thoracic region, our chest wall, and in the lumbar, lower part of the spinal cord, the messages get to the muscles of the leg. And this is the way we get messages to muscles to go ahead and move. And if there's degeneration of that upper and lower motor neuron, of course, the messages don't get through, the muscles then don't move, and by not moving, they atrophy because they don't have any input. Next slide. So when there's damage to the upper motor neuron alone, that causes stiffness and slow movement. And on our examination, we'll see an increase in reflexes and reflexes that shouldn't be there. When there's damage to the lower motor neuron, we see a weakness. We see a funny twitching. Our doctor speak is called fasciculations. There's going to be cramping, and then that thinning of muscles called atrophy. So when we see symptoms or signs of upper motor neuron increased reflexes, for instance, but yet the muscles are weak and atrophied, that's one of the hallmarks that we're dealing with ALS. The sensation will be normal because sensory nerves aren't involved. And typically it is painless except for the cramping. So those are clues, and we try to educate other physicians about the clues so that folks can get to clinics earlier and get on treatment earlier, because we do have treatments. Next slide. So, how does ALS start? Well, it can start with speech and swallowing in about 20%, or in the arms and legs the rest of the time. And it's about 40% one arm, or 40% one leg will be weak. It's painless and it spreads. The diagnosis is one of exclusion. Why? We have no biomarker, no test, no one test that says this is ALS. And that's why when we talk a little bit about research later on, that's why biomarkers are so important, because the earlier we diagnose, the sooner we'll be able to start treatment, especially those treatments that slow the disease down. Think about it. If something only slows the disease down and doesn't stop it, the sooner we start it, the better off you'll be. And we have to rule everything else out at this point that could damage the motor neurons. The average time to diagnosis is actually atrocious. It takes 14 months from the first symptom to the time when somebody actually gets a formal diagnosis. And that time's a little variable. For women, it's even longer. And for people who start with speech and swallowing problems, it's a little shorter. The progression is variable, but typically there is progressive weakness, then problems with speaking and swallowing, and problems with breathing, with an average lifespan of about 3 years. But again, variability. And so 20% of people living with ALS have a slower progression and more than 5 years. Next slide.
Do you want to mention anything about the picture at the bottom?
Yes, we certainly can. This is just to show you that this is progressive and that it can be rapidly progressive. Now, people living with ALS who are listening to this, you know this. I want the people who aren't living with ALS and their family to see this. And this shows you the course of one individual over 1 year. And you can see going from walking to a power wheelchair to being on a breathing machine to stay alive. And I want you to see him holding his little girl. So, for those of you who don't know ALS, I want you to see this. And it's not just the person living with ALS. It's the entire family that is affected by ALS. And I want to say that we always try to keep this in mind and in our hearts, that it's not only the person living with ALS, their children and their spouses and their caregivers. And it's when children become caregivers, when they're 10 and 11 years old, that the real effect can be seen. They live with that the rest of their lives. Next slide. So who gets ALS? The annual incidence is about 1 to 2 in 100,000, which means the prevalence is about 3 to 5 per 100,000. And think about that as like 30 per million. There's about 15, well, the statistics vary, but anywhere between 15 and 30,000 people at any one time in the United States living with this disease. The annual incidence is the same as MS. But everybody's heard of MS. Everybody knows about MS. Lots of people around who have MS. The issue is, because of the shortened lifespan and the availability of many life-prolonging treatments in MS, our prevalence is much lower than MS. There is a slight male predominance, and this is the statistic I want you to look at, because I don't care whether you're someone who is in a family with ALS or you're just listening to this to learn more. Everybody's lifetime risk to develop ALS is 1 in 350 to 400. That's your chance of getting ALS sometime in your lifetime, and that isn't that small. The mean age of onset is 54, but we've seen 18-year-olds. We've seen 90-year-olds. The general majority of cases are really between 45 and 70. It tends that people who have familial ALS are younger. There are some occupational clusters, and these are really pretty important to us. Gulf War veterans and people who are in the military service period. And so this has become a military-related disability. And so if you are a veteran and have ALS, or somebody in your family is a veteran and has ALS, there are services available through the VA. And 5 to 10% of folks have a family history of ALS. Next slide. And we now have identified over 40 different genes that, when altered, when mutated, can underlie a susceptibility to ALS. The first gene ever identified was SOD1, and that was identified back in 1994, and it took more than 10 years to really start to see the next grouping of genes identified, and things have now accelerated. And why have they accelerated? Well, we've got better techniques, okay, and machines that can sequence faster and can make it inexpensive. We can sequence a whole genome for under $1,000 now. We got better statistical techniques, but I want to stress the one thing that's really made it happen: collaboration across countries and across the world, with everybody contributing genomes from people living with ALS and controls, so that we can compare. And we've identified the most common cause, our mutated gene that can cause ALS is called C9orf72, and it causes almost 40% of familial ALS. And SOD1, the first gene, is only 2 to 5%. Now, remember, if you recall, 10% of ALS is familial, and 40% of that, or 4%, is caused by C9. In addition, and this is also important to understand, that even in people without a family history, we can identify genetic changes. And in fact, the C9 mutation, or it's actually a repeat disease, the C9 abnormality is present in anywhere between 4 and 7% of the sporadic population, and upwards of 11% of sporadic folks have a genetic abnormality. I tell you this because I would advocate for everyone getting genetic testing to look for this. And why? Not only to know if you carry a gene and if your children are susceptible, but because we are working on genetic treatments for SOD1, for FUS, and for C9. And if you have one of those, you might qualify for a clinical trial. Those of you who are pals out there, for those of you who aren't, these are going to be the first, I think, the first kinds of ALS where we'll actually be able to stop the disease with treatments, not just slow it down. So it's immensely important that we get a better understanding. And in addition, these 40 genes that are identified have really led to a better understanding of mechanisms. And if you look on the next slide, we can see that there were a lot of mechanisms that were seen in ALS folks without any family history, that now that we've identified all these genes, the genetic changes support where the problems are. And so, as you can see in this slide, I've listed 10 implicated pathways. And under each of those pathways, on that picture of the nerve cell, you can see the different genes are segregated by which mechanism they impact. So all the mechanisms that we had previously identified, there are genes also associated with those pathways that, when damaged, can cause ALS. And those pathways, these implicated pathways here, they provide targets for treatment. The problem is, and they're not mutually exclusive. So I can have disease and there may be more than one pathway that's causing the problem. And we need biomarkers. You hear that over and over again. We need biomarkers that will tell us which pathway in an individual might be causing or driving the disease so that we can target that pathway in that individual. That's called personalized medicine. That's what's happening in cancer. That's what we need to happen in ALS. And so the most important pathways are the way the nucleus of the cell, that brain of the cell, passes things back and forth into the cell cytoplasm, the fluid of the cell, the way RNA and DNA is metabolized. There's also problems with protein handling so that there's abnormal clumping of protein. And you may have heard of something called TDP43, which is a protein that's clumped, and it can be found in virtually 98% of ALS, whether it's familial or sporadic. That clumping of this protein, TDP43, has been identified. DNA repair. Now, I'm going to spend a moment on mitochondrial function and oxidative stress. Why? Because the drug AMX0035, which recently was shown to have an effect on disease, targets oxidative stress and mitochondrial function, as does edaravone or radicava. Both of those drugs work at that level. The AMX0035 also works on protein handling. So you can see that we are successful targeting some of these pathways, but we're not as successful as we need to be. We all know about neuroinflammation, and neuroinflammation certainly has been implicated by some of the genetic defects, and even the microbiome in ALS may implicate neuroinflammation, because certain microbiomes, the bacteria in our gut, depending on the composition, can drive the brain-gut, the microbiome or gut-brain interaction, and drive neuroinflammation. And we know it does it in other neurodegenerative diseases. Then the sort of trafficking system in nerve cells that gets things from that brain down that long axon, that long process that goes out and extends to muscle. That's the cytoskeleton and axonal transport. It's really, you got to get things back and forth to the main cell and down to the muscle. And that's been implicated as a mechanism for disease. Shuttling of cargo in the cell in these vesicles has been implicated. And finally, again, excitotoxicity, one of the earliest theories that normally glutamate is an amino acid that you need for nerve cells to talk to each other. But if there's too much glutamate, it actually damages nerve cells, and that's called excitotoxicity, because glutamate can excite, but in too much concentration can be toxic. This is where riluzole probably works, is on reducing the amount of glutamate and reducing excitotoxicity. So as you can see, this is important, and genetics has been important in informing mechanism and also in supporting the theories we already had. Next slide. And of course, there is an overlap in, it's a continuum. We think neurodegenerative diseases share many mechanisms, and there's an overlap, and 10% of people living with ALS can have frontotemporal dementia, and 40% can actually have cognitive involvement, have some sort of involvement that doesn't really impact nearly as much as having a frank dementia. And both ALS and FTD as separate entities share pathologic changes like those clumped proteins and that TDP43 being in the wrong place. And they share a number of genes that when modified or mutated can actually present either way or as both. So, and C9, that most common of all of the genetic changes in ALS, is one of those genes that sometimes people can have frontotemporal dementia, sometimes ALS, and sometimes both. And sometimes we know that people can carry a mutation and not manifest it at all, not have any disease. And we have to figure out why, because that's going to be a key to treatment. There's clearly, I personally have a bias towards having other genes that are modifiers of the mutated gene, but it may also be because you have to have a combination of a mutation and an exposure in your environment. We don't know yet. We got to study that. It's a gap in our knowledge. Next slide. I'm going to turn it over to Mary, and I'm sure you're ready for that now. Mary, please go ahead.
All right, thanks, Dr. Patterson. So, yeah, thank you so much for that explanation, and to talk about, just all the different, the challenges within the targets and the complexity of this disease. And as the researchers and scientists continue to, every day unfold and discover more about moving closer to, potential cures and treatments for this, there's still a lot that has to be done in terms of caring for people that are living with this. So, some of the main things that certainly we try to practice and bring to people at our center, but also too, that's just, consistent throughout the care of those with ALS from multidisciplinary centers that we'll talk about are definitely compassion and hope. We are the MDA ALS Center for Hope, and we don't take that lightly. So giving the diagnosis and prognosis, that is really an art, I have found. So having the honor to kind of sit with Dr. Patterson and also our co-director, Dr. Anahita Dabu, when they have these conversations with patients and families, it is done with such care and genuinity and just compassion, because this is certainly not an easy diagnosis to give at all. Multidisciplinary care to maximize independence, and the quality of life, because that's really what one of our main focuses is quality of life for our families. How to manage the disease, how to manage the symptoms, respiratory and nutritional support, which we'll talk a bit about as well. Disease-specific medications, Dr. Patterson mentioned Riluzole already, and there's Radicava as well. Emotional support and education, which we feel very strongly about also. So we'll kind of give a bit of high-level information around all of these. All right, so it definitely takes a village. That is no cliche in the care and practices and working with ALS. It absolutely is a team approach. So multidisciplinary care has been shown to improve quality of life, actually even to improve longevity in those living with ALS. And as you can see just from this slide, it really does take a village. ALS affects, and any of you that are listening that, like Dr. Patterson was saying, that live with this, that ALS just affects every area of life, and it takes a lot of people. So physician, nurse, research, of course, nutrition, psychology, social work, physical therapy, respiratory therapy, assistive technology, occupational therapy, speech and language pathology, and then, extensions, the family, of course, friends. We often, put care teams together that involve all sorts of extension of friends and resources and coworkers potentially. Specialty physicians, pulmonologists, palliative care physicians, gastroenterologists, ear, nose, and throat doctors, home care companies for, in-home physical therapy, for hospice companies, palliative care companies, respiratory companies, community organizations. Dr. Patterson already mentioned, the VA. There's lots of organizations and foundations that support in various ways families and people living with ALS. Other community organizations, support groups. I mean, all sorts of things. So we really, when people come to see us, and really what people with this disease really need, their families and themselves, is a whole care team and a support network. So if somebody's in somewhat of a private introvert, guess what? You're going to be overloaded with, we often say, we become your extended family. So you'll get sick of us, but we hope not, because we journey with them. So from the time of diagnosis, which, and we may be with patients and families for, 3 years, 5 years, however long that they continue with us. So it really is quite a relationship that's built, which we're so incredibly honored to be part of. So what does a multidisciplinary visit entail? So, and this is, for anyone that, of course, is living with the disease of ALS, hopefully you are connected with a multidisciplinary center. If not, we would highly suggest and recommend that. Just because it is this kind of one-stop shop model where all of your needs, because there are so many needs that go along with this disease that need to be addressed. So it absolutely, and like Dr. Patterson mentioned, we really do involve, it is the whole family. So it really has to involve the patient and the whole care team, the care partner, the loved one, whomever that may be. Appointments can last for a few hours. People come oftentimes and they are there addressing their needs, depending on how many needs they have. They may see whomever from the multidisciplinary team they have needs for, or they may see everybody on the team who can then do their own assessments. And even possibly that's how our model runs in our center. And oftentimes what happens is that we may uncover in our clinical assessment something that the person or family member may not have even known was an issue. So sometimes that can be quite helpful, addressing needs that may not be in the forefront of someone's mind. We perform repeated monitoring, which can be really helpful along the continuum, and vital signs, weights, respiratory status, functional ability, and things like that, and just their medical status, the emotional status, the mental health. And we are able to kind of monitor these across a continuum, and which also helps us, of course, take care of any needs that are current, but also helps us plan for what might be coming in the future, because it is somewhat our job to, even though everybody has their own kind of individual physiologic development and journey with the disease, we somewhat know and can kind of plan out the course in a way to know what steps are coming ahead. So one of our goals with families is to really help them plan for what's coming. We perform assessments and address all the needs and changes that have occurred and that are occurring and that may occur. We make recommendations for current needs as well as future planning. Connecting people with resources, social work, patient services coordinators, they're really, really integral in terms of the care and support of these families. Offering support, really helping them feel like they're not just another number and they're not out there alone, really helping them feel like they do have a team that cares a lot about them and wants the best for them. Education, huge piece of everything. I often will say to people that, my hope is to give you all of the information that we are aware of so then that you can make the best decisions for yourself when you need it. And then there's also a whole other subset of support that happens between these visits, because oftentimes a visit will happen maybe every 2 to 4 months, and we know that many changes can occur in between clinic visits. So there is so much coordination and triaging and support that goes into helping the families and the people living with ALS in between visits. So someone a couple of weeks ago actually said to me, "What do you do on the other days that you're not in clinic?" I thought, oh my gosh, there's so much for us to do. So let's just talk, and we're not going to go into real deep dive into this, but just to give a sense that, there can be a lot of medical symptoms that arise, living with the disease of ALS. The GI system slows down, something called peristalsis. We know that GI motility slows down with lots of neurodegenerative diseases, but yes, with ALS. Fatigue can be an issue, lots of sleep difficulties, and that can come from a lot of different things. It can come from breathing problems. It can come from discomfort, physical discomfort. It can come from the mental discomfort that some people feel. So these are all things that we try to address, dry mouth, excess saliva, finding balances. And sometimes there can be, medical management for some of these symptoms that may arise. Thickened secretions, which can become a real problem for people, especially if they have breathing problems as well, and then swallowing issues. So what we hope to do is stay in, that our families and people living with ALS stay in close contact with us when situations and issues and new symptoms are arising, so we can help prevent, if possible, or address any of these symptoms before crises occur. Stiffness in the muscles, of course. Range of motion is really important for that, and we'll talk a little bit about that. Mood, depression, anxiety, all sorts of things. Cramping, and Dr. Patterson mentioned that a bit. Cramping can be, as a direct result of some of the motor neuron damage. Lability, so emotional lability, labile affect, which is very different than depression. It's something called pseudobulbar affect, and it's really just an inability to control our laughing and our crying. This is and I always tell people this is a very emotional time. So there can be excess of crying and things like that. But emotional lability, this clear PBA, pseudobulbar affect, really has a different flavor. And that's one of the things that we try to decipher. What's depression or mood or adjustment reaction, and what might be this labile affect. Anxiety, like we mentioned. Urgency, urination, absolutely. So laryngospasm, it's tightening of the larynx, and then, like Dr. Patterson mentioned, fasciculations. And there's others. And this is really just to show that, yes, there are, if you've never been on medicines before, which is actually common for a lot of people with ALS, and now you come in and now you might have a whole new set of different things, which can take some adjustments. So there are things that we really talk about. And certainly try to, if there's any lifestyle managements that we can do before we move to medications, we try to do that. So just to kind of highlight some of the major areas that can be affected with ALS, respiratory is probably a number one. What do we try to do in respiratory care? So we could have certainly a whole talk on each of these, but preventing and treating infections, that's really, with all of these things, we're trying to prevent any crises from happening. So preventing and treating infections, nutrition is really important. In adequate nutrition, we have another slide on that, but just really being able to keep up adequate nutrition, because that, of course, can affect our whole cycle if we're malnourished. So aspiration prevention, there are devices that can help us with that, and also safe swallow that we're going to talk about, video swallows, controlling secretions. We can do that with medications. We can do that sometimes with various medical devices like a nebulizer machine, strengthening respiratory muscles early in the disease. That's actually something that we practice in our clinic, teaching people breath stacking, which helps to kind of build one breath on the next, and expiratory muscle training. Because we know, the diaphragm, as it gets weakened, it's a muscle in the body, it gets weakened as well with ALS. And that's that muscle that helps our lungs inhale and exhale. So if we can help people maintain and really strengthen that expiratory muscle early on, that can benefit. Respiratory clearance. That's actually really, when we're moving around as normal able-bodied people, our lungs are mobilizing our secretions. There is kind of adequate respiratory clearance typically. But if we're compromised, and of course, if we, can't walk around and really be as active as possible, and then you have excess secretions and all sorts of things, you can really get into some trouble. So respiratory clearance is really important with chest percussion, being able to prevent those infections from happening. Ventilation and pulmonary clearance, again, pulmonary clearance. And ventilation. So there's, non-invasive ventilation, and there's also invasive ventilation. Invasive ventilation, of course, is via a tube, and we're connected to a ventilator. And then there's non-invasive ventilation, which is in ALS patients is used via a BiPAP machine. And that can help the diaphragm and help the lungs just blow off that excess carbon dioxide. We always having respiratory therapy involved in the multidisciplinary care, and sometimes and often a pulmonologist is absolutely paramount. We refer to them often, so that is a huge piece for people with ALS. And then talking about nutritional care, and all of these really play in together. What we do, monitoring weight, it's really important. We know that people with ALS are hypermetabolic. So weight loss is a huge issue for people with ALS. Plus, if you have a swallowing issue and you have GI slowing GI dysmotility, then you're going to get, satiated and fuller faster. So there's all sorts of things that can play into weight loss for people. Monitoring GI functions. Are people having, adequate bowel movements, frequent enough bowel movements? Are they constipated? Talking to people about safe swallow, and chin tuck, teaching people a maneuver called a chin tuck. Some people listening might already know what that is. Controlling secretions, again, that kind of goes across the board into a lot of areas. Aspiration prevention, oftentimes we'll do what's called a video swallow, and they're, via x-ray, they're looking and watching people swallowing to make sure that there's not any food or liquid or saliva going into their lungs. We teach people the Heimlich maneuver. It's rarely used, but we'd like people to know how to do that just in case they need it, and teach people about, choking and, what to look for if somebody's airway, how to know if somebody's airway is fully blocked and things like that. Adequate hydration is important, especially when, it's difficult to drink thin liquids. How do we get them hydrated? Modifying diets. And these are things that our nutritionists and our speech pathologists talk to people about all the time. Weight loss management, calorie packing, using supplements. Then, of course, having the discussion. This is a life choice about feeding tubes. And what does that mean? What does that look like? What does that entail? So we also, using our nutritionists and our dietitians, our gastroenterologists and our speech pathologists as well. Just quickly here about speech in ALS as well. So watching for, any and early speech changes for sure, modifying our speech patterns, teaching people how to do that, controlling secretions again. Our speech pathologist talks to almost everyone about something called voice banking, where you can actually record your voice and be able to use that later if you do lose your speech. Talking alternatives, just writing, letterboards and other ways to, have an alternative way of communicating if speech is lost or difficult. Assistive technology support, using apps on people's phones or computer technology, speak to text, TTY, old and new. Speech generating devices, there are things maybe everybody doesn't know, but there's something called an eye gaze system and various different levels of speech generating devices that people can actually type with their eyes on a computer, and then that will actually speak for them. So our speech therapist works closely, of course, with our occupational therapist and our nutritionist, our dietitian, myself as the nurse, and all of us in really helping, optimize people's lives and their daily living. And just to, again, briefly go over mobility care, because these are the, main areas that affect somebody living with ALS. What we do from a multidisciplinary standpoint and what's appropriate for everyone with ALS is monitoring their strength changes, talking to them about appropriate exercise programs, how important range of motion is all along the continuum, so contractures don't happen, which can be a real source of pain and discomfort for people. Talking to them about activities of daily living, and that's more along the occupational therapy area. What modifications, toileting, eating, dressing, bathing, all these activities of daily living that a lot of us, take for granted. And, once somebody begins to lose function of their, forearms and their hands, maybe even their shoulders, not being able to get up to, lift your arm and hand to, just do your hair or brush your teeth, even to feed yourself. It's a huge gap in being able to function in your daily life. So that's a huge adjustment for people. Talking about safety needs for the home, work environment, how are we moving about in a safe way? What adaptive equipment or assistive devices may be needed? And this all, this is, as we work as a team, why a multidisciplinary team can be so helpful is because we all work together, the social worker, the PT, the OT, in terms of boosting up, as much support as possible. Talking about home modifications and sometimes housing adjustments, meaning that sometimes people, make decisions that, they need to leave, that their home is not, they need to find a more appropriate, housing situation for themselves. And we often will talk to them about that. Safe transfers in and out of cars, up and down from chairs, whatnot. access in and out and around the environment, whether it be, via ramps, whatever cars they're using or a truck or whatever it may be. And then also, still addressing also, their recreational needs and interests. How can I get to my, child's sports event? How can I go to the concert that I love to do? So really, how can I get to the baseball game? And, we talk all about these, maybe there's our social worker or patient services coordinator will talk to the event facility about handicap access. All of us work together to make sure that, the person, if they still want to, that they can do the things they want to do for optimal living. And then, of course, outpatient or in-home physical therapy, occupational therapy, which is really incredibly vital for people along the continuum. So mental health support, which of course is my passion for sure. And I actually see this as necessary at every stage. I mean, all of us address everything along every stage, and that the mental health support, that it really does involve the care partner and the family, the loved ones, anybody that's involved, and also the person living with ALS. And you think, wow, this is a lot to jam pack into one office visit, right? So that's why a lot happens in between visits as well. And that, mental health is incredibly important because it can impact like almost every experience. There's so many adjustments and new things and changes that people have to make with living with this disease, that just the adjustment, going from somebody that was never ill to having to maybe take all these medicines now, or having to make these life decisions, now having to use an assistive device to walk or something like that. So the mental health and the adjustment piece, and helping people as best as we can to adjust to these changes as they're happening, while trying to maintain and hold on to some joy and hope as well, is really the overall goal, right? Assessments, we often do assessments for mood changes, depression, anxiety, like that PBA that I mentioned. Medication management, there's really, times where medication for mood and anxiety can be really beneficial and helpful and needed. Communication and stress management strategies is probably something I talk to families and patients about all the time. Communicate. So important. Individual and family counseling. Yeah. Do people need extra support? Life decision making, advanced directives, that's the AD. Advanced directives, are medical wishes, end of life choices, end of life issues, all these conversations that, oftentimes are seen as really, and can be really difficult to have these conversations. And they're so important, and they're things that we try to address along the continuum. Support groups and resources. The ALS Hope Foundation offers some support groups, and there are various support groups for different things around the country and internationally as well. So we really try to hook people up if they're open to those things, and just see where we can help people adjust as best they can. So that, of course, is enough from me for now. So I'll now turn it over to Dr. Patterson, and she will talk more about research. Thanks.
Just closing up, because certainly appreciate your attention for this presentation, but we really need to make more progress. The need is urgent. We all know that, but I need to underscore we are making progress. And part of the reason is the collaborative research that's developed using pooled resources, things that we put together instead of having a tissue bank over there at one university and another at another. We're starting to put things together, and these resources can be used to understand the disease clinically and pathologically in terms of using autopsy material, and also to find those biomarkers that I've been talking about throughout, because they're so critical and it's a really urgent need. So we have tissue and autopsy banks. We have genetic resources, which means genomes that we've collected from people living with ALS, as well as people who aren't, because we need to compare. We're developing newer animal and cell models, including those derived from people. So, taking skin cells and making them into neurons in a petri dish. All of this is enabling us to get the answers faster. And whether or not those what we call iPS cells, those pluripotential cells that we make into neurons, will provide a way to individualize medicine later. We don't know yet, but it may identify mechanisms in an individual that are more active and that should be targeted. And there's now a lot of academic and pharma working together. Nobody's the good guy, the bad guy. We just need to work together to develop new ideas. And the consortia working together are working in understanding how genetic changes result in disease, why you can carry a gene and not get the disease, and why some people get it and some people don't, developing the biomarkers, following up on agents that may provide treatment, leads, studying motor neuron biology and understanding it better so we can understand better what goes wrong, and also the importance of epidemiology. Why is it that there's a higher incidence in veterans? So, and there's much more. This is just the tip of the iceberg on what's going on in basic research, and basic research is going to lead to clinical treatments. That's called translation. And you know, what have been the challenges? The challenges to us in doing trials is, I already told you, the diagnosis is delayed. Remember, I said that it takes up to 14 months, and it's longer if you're a woman, shorter if you're bulbar. And if something's going to slow down the loss of neurons or stop it, you want to get somebody on treatment as early as possible. And the variability, the heterogeneity, both in terms of the clinical presentation, how people look when they present, as well as genetic changes. And that genetic, there's 40 different genes that when mutated can cause disease. You can't tell me everybody looks the same. That's called a phenotype. They have evidence of upper and lower motor neuron damage. They may present a little differently, and some have different genes, but that isn't one disease. If just looking at familial cases alone, there's been 40 genes identified. Is that 40 diseases or one? The variability, because of the variability in how fast it progresses and how long people live, if I'm designing a clinical trial, there's going to be lots of noise unless I increase the number of people. How do I get the numbers down? And that's going to be biomarkers, so that if I have a drug that's aimed at oxidative stress, for instance, I need a biomarker that tells me this is the group of people most likely to respond where oxidative stress is driving their disease. Enrollment and retention. More than 20% of people withdraw from trials. If I have withdrawn subjects, I lose that data. It doesn't contribute. It messes up the analysis. I need to include more folks. You know, in addition, going back to biomarkers, not only do we need biomarkers that will identify mechanism, we need biomarkers that will identify that we're making a difference in terms of nerve degeneration, that tell us that the rate at which motor nerves are dying has been reduced or stopped. And so developing those kinds of biomarkers will enable us to do trials faster, because our endpoint would then be a change in that biomarker. And so this variability, just, you know, what target do you choose? Who do you include so that you sort of enrich the population by predicting who's going to respond to your drug? What endpoints do you use? You know, is it going to be a clinical endpoint, survival? If I do survival, that's going to take longer. We've talked a lot about stratification. So these are the challenges. You know, people say, why don't we have anything yet? We're lucky. We have 2 drugs that are approved. We've got a 3rd drug coming down the line, and it's been approved in Canada, the AMX 0035, riluzole and radicava. We have many drugs in trial, and hopefully some of those will come to fruition. And we're getting smarter about trial design and developing these kinds of programs to help us do better trials. And we have, of course, the platform trial, where we're actually testing 4 drugs at once So instead of doing 4 sequential trials, heck, we're going to do 4 drugs that are overlapping and share a placebo group. What that means for people living with ALS who participate, they have less of a chance of being in placebo and more about getting the drug. And then, you know, our pipeline, this just shows you all the drugs that are in the pipeline. And I've sort of organized them based on what they're targeting, what mechanism that we talked about before they're targeting. And the point of this is that there's a lot of irons in the fire, and we're going to cross our fingers and hope that some of these are going to be added to our arsenal, that we're going to have some more treatments for ALS. Right now, we're making progress because we can slow the disease down. We want to stop it. And then we can worry about how to make people better by neuron repletion. That's a long way off. Right now, we just want to stop the fire. We want to put that fire out in your nerve cells. Next slide. So everyone can help. Participating in research, even if you don't have the disease, we need controls. And we need people living with ALS to trust us and to participate in clinical studies. And not only clinical trials, you can hear how important those biomarkers are, and also developing those collaborative resources that can be used to understand the disease, to understand its natural history, and to start to stratify the population. And we also, and this is one of my pet peeves, while we're looking for the cure, while we're looking to stop disease, how do we best care for people living with ALS, given the tools we have now? How do we maximize? NIV, non-invasive ventilation, makes a huge difference. It's better than anything we have. It can extend life up to 14 months, 11 to 14 months for people who are able to tolerate it. That's better than any of the drugs we have. How do we make it even better? Because how do we make people who don't tolerate it, enable them to tolerate it? What causes that intolerance? How do we figure out when to start it properly? How do we figure out how to maximize the effect? You can also help by advocating. Advocate for legislation to pay for the treatments that we come up with. We need insurance to cover treatments. We're always fighting. We need policies that enable and think about people living with ALS and always incorporate their feelings. The FDA is trying to do their part. They're trying to mobilize things faster, but advocacy has enabled that. I can't tell you how important advocacy has become and how important and what a huge role it played in the Act for ALS, which is increasing our funding for ALS research in all these areas. And of course, don't forget, it's not, it may seem mundane, but, people living with ALS are taken care of by their local clinics, and that local clinic needs your help. And so fundraising and helping out your local clinic that's really in the trenches to give good care, to enable research, including just collecting resources to share with larger repositories, as well as independent research within their labs, is so important. So while you're raising money for the large organizations, remember the people who are in the trenches with you and who take your calls. I think that's really important, because those of us who are running clinics know the struggles we go to maintain the funding to keep our clinics going in that multidisciplinary fashion. And you can always volunteer with any of the organizations. We love you to volunteer with us, but anywhere your heart is to volunteer. And that doesn't mean, you don't need to give money, but give your support, your time, your talents. Everybody has talents. Everybody can do something that helps move the needle, that would help us get to where we need to be. And we need all of you. And that's why we wanted to stress how important this is. And here at the Center of Hope, we have a translational program, which includes our clinic and our basic research lab in our clinic. We study drugs in the animal models. We study genetic modifiers of disease, and we participate in national tissue bank collections, as well as having our own tissue bank that includes autopsy as well as other tissues, serum and urine and spinal fluid. Our clinic, of course, not only, look, let me stress, the most important thing in our center, above and beyond anything, the basic research and the clinical research, is good clinical care. So clinical care and educational programs are the #1 priority. But to push the needle forward and not be doing the same thing next year and the year after, we need clinical research on how to best use non-invasive ventilation, how to best do nutrition. We think this is really important because we don't want to be doing the same thing 10 years from now. We want to do better using what we have while we try to find things that will stop the disease. And that's why the clinical trials become so important, and participation by people living with ALS becomes important in clinical trials. And families, spouses, people not living with ALS, we can use your help in clinical research because we need tissues from people who don't have ALS for comparative purposes. So please remember that. For those of you who are listening, please consider helping any of the clinics in your area to make progress, because we're all in it together. Thank you so much, and thank you for caring about ALS.
Thank you so much.